Thanks for joining the team from Advanced CPR Solutions today. In this video, you'll be presented information about the physiology of resuscitation, as well as the physiology of a comprehensive bundle of care aimed at improving outcomes for our patients. Throughout this presentation, we'll be referring to the ELIGARD patient positioning system simply as the ELIGARD system or the ELIGARD. This presentation is part of a series of educational videos that should be viewed together. These videos should not be your only source of information to gain proficiency with the ELIGARD system. You should review the instructions for use and participate in initial and ongoing skills training. You should also be familiar with your agency's specific equipment and protocols. And note that any benefits or clinical improvements discussed here are based on preclinical and limited clinical data.
Today we're going to talk about the physiology of CPR. My name is Keith Lurie. I'm a cardiologist and resuscitation researcher. In 1960, closed chest manual CPR was first described, and since that time it's been the standard of care for most patients around the world. We're going to talk about conventional CPR and how it works, and then we're going to talk about how we can make it better. I'd like to break down CPR into the compression and decompression phases and the ventilation phase. We all know when we compress the chest that the pressure inside the thorax goes up, and that's shown very nicely in this little balloon model. We have the lungs that are blue balloons, and we have the heart that is a red balloon. And when you push down on the thorax, you see that the heart gets squished a little bit and blood gets propelled out, not only to the coronary arteries of the heart, but primarily to the brain and the rest of the body. And when the chest wall is allowed to recoil, then a little vacuum is created inside the thorax, and blood comes back into the heart, and some air comes back into the lungs. And when that air rushes back into the lungs, that vacuum is destroyed. And that's what we do most of the time when we do CPR. And then some 10 times per minute, we provide a positive pressure breath. When we inflate the lungs, the pressure inside the lungs goes up. The pressure inside the thorax goes up, and that pressure is transmitted immediately to the brain because there are veins that run along the back of the spine, along the spinal cord, called the paravertebral venous plexus, and they instantaneously transmit pressure from the thorax to the brain. So you push down on the chest, intracranial pressure goes up, and blood goes to the brain. You allow the chest to recoil, intracranial pressure goes down, and some blood comes back into the heart. It's not a very efficient process. In animals, 15 to 20% of normal blood flow, enough to get some people back, but it's also one of the primary reasons that survival rates have not really gone above 10% nationwide since 1960. And according to the most recent data from the Cardiac Arrest Registry to Enhance Survival, neurologically intact survival rate nationwide in the United States is just about 8.5%. So that's about as good as we can get with a pair of hands. Now, when you get to the scene of a patient in cardiac arrest, if they're lucky, they are gasping. So when somebody goes down and they still have some oxygen in their brain and their brain senses that they're in trouble, they take their so-called last gasp. And that last gasp is a complicated bit of physiology. Clearly, air rushes into the lungs to provide some oxygen, but that gasp creates a vacuum to suck more blood back into the heart. It creates a vacuum to pull venous blood out of the brain. And it also tells the rescuer that the brain still is alive enough to trigger that gasp. And so if you come across somebody who's gasping, don't give up. If you have the combination of gasping and a shock of a rhythm like ventricular fibrillation, that patient has a 57 times higher likelihood of survival compared to no gasping and no VF. So let's talk a little bit about ventilation. When you provide a positive pressure breath to the lungs, we inflate the lungs, and that also opens up the blood vessels so that you can have circulation from the right side of the heart to the left side of the heart. If you inflate the lungs too often, so-called hyperventilation, then the pressure in the thorax is always positive, and you never have any way to get venous blood back into the heart or out of the brain. And we showed many years ago that hyperventilation can be deadly. What about no ventilation? If you don't ventilate, maybe it's okay for a minute or two, but over time the lungs collapse. And this atelectasis prevents blood from going from the right to the left heart because the blood vessels are collapsed too. And it also limits the way you can provide oxygen to the brain. Many years ago, we showed that no ventilation or too much ventilation were both dangerous. So there is a sweet spot, somewhere between 8 to 12 breaths per minute and about 500 cc's to 600 cc tidal volume. Ideally, you want to deliver it during the upstroke. So over the last 25 years, a number of us have been studying the physiology of CPR and created devices to really almost normalize blood flow to the heart and to the brain during CPR. So I'm going to talk a little bit about that. Let's start with moving blood out of the thorax, beginning with a suction cup-based device. When you pull up on the chest and then push down, you create a vacuum inside the thorax, not unlike when you take a deep breath or you gasp. And that vacuum clearly pulls some more air into the lungs. But if you block air from rushing into the lungs with a little impedance threshold device, as you can see in this little model again of the heart and the lungs, then each time the chest is allowed to recoil, either manually or with a suction cup device, you double or triple the amount of blood flow that comes back to the heart. So when you push down again, you double or triple the cardiac output. That combination has been shown in pigs and in people to result in improved survival. And in fact, 50% more people are alive at the end of a year in one large study by Aufderheide and colleagues published in Lancet compared to conventional CPR. We call that active compression, decompression, or ACD CPR. And we call the impedance threshold device the ITD. So if you use the combination of ACD and ITD, that's better for the patient's heart and brain, but still not good enough. About 5 years ago, we discovered that if you elevate the head and the thorax in a controlled sequential manner, a technique we called elevated CPR, then you can actually nearly normalize blood flow and cerebral perfusion pressure in animals in cardiac arrest. And most recently, this approach has been used in patients with great success as well. So how does all this work? Well, let's begin with a new understanding of what happens when you push down on the chest. When you push down on the chest, we know that intrathoracic pressure rises, and we also know that intracranial pressure rises. But we had forgotten about the fact that you have an arterial wavefront that goes to the brain and a venous wavefront that goes to the brain, and the poor little brain is squished in between these two waveforms or pressure waves each time you compress on the chest. It's almost like having a concussion with every compression. But if you elevate the head, there's some place for the venous blood to go. It drains out back to the heart because of gravity. That can't happen when you have the body flat. And the venous blood can't go back to the heart so easily because each time it's compressed, there's this waveform that's carrying a venous pressure wave towards the brain. So elevating the heart relieves the venous pressure from the brain during the decompression phase. And it's very dramatic, as you can see in this figure. What else happens? Well, we refill the heart more efficiently. We provide more blood back to the heart. We increase preload. Now, you can't do elevated CPR with just a pair of hands without an impedance threshold device. At a minimum, you need an impedance threshold device because you need more blood to be pumped up to the brain because you're asking the rescuer to pump blood uphill. But the combination of active compression, decompression with a suction cup-based device and an impedance threshold device works quite well with elevated CPR. But it's still not quite that simple because you have to prime the system before you really elevate the head. So we created a device called the EleGuard, which elevates the head in its lowest position about 12 centimeters and the heart about 8 centimeters. And this is a patient positioning system that can be used during CPR to position the patient so that When you place the patient on this device and the head is elevated, physiologically, venous blood is already being drawn out of the brain, even in the lowest position. In animals, that's about 50% of the benefit, actually, of the elevated CPR method. And then we've learned that you can't go up too quickly because you'll bottom out the pressure head. But if you come up slowly over 2 minutes, then in pigs, we've shown you can normalize cerebral perfusion. And so a device was created to position the head and the thorax in humans during CPR to mimic what we saw in animals. That combination of active compression decompression, an impedance threshold device, and the ELIGuard can be used to improve physiology and nearly normalize circulation based upon the animal studies that were performed to demonstrate this physiology definitively. So now let's step back. What have we learned? Well, we like to break CPR physiology down between the compression phase and the decompression phase. The compression phase forces blood out of the heart. The decompression phase allows you to refill the heart. The decompression phase also allows venous blood to drain out of the brain, so you make room for better arterial blood. And then we have to periodically ventilate to open up the airways and the blood vessels so that we have better circulation, both blood and oxygen. And then we learned that we can take conventional CPR and basically put it on steroids. We elevate the head slowly, we use active compression decompression, we use the impedance threshold device, and based upon animal studies, we know we can provide much greater blood flow to the heart and the brain, and that provides a much greater chance for the result we all want, which is more patients alive at the end of the day. Thank you.